Bismillahirrahmanirrahim. Now, what is chronic blepharitis? Chronic marginal blepharitis pathogenesis is anterior. It can be anterior blepharitis, it can be posterior blepharitis, or the angular blepharitis. Anterior blepharitis may be staphylococcal, partially immune mediated, and or it can be seborrheic, often associated with seborrheic dermatitis. So, anterior blepharitis can be staphylococcal or it can be seborrheic, double S. Then posterior blepharitis is associated with the MGD, that is meibomian gland dysfunction, with alterations in meibomian gland secretions, often associated with the acne rosacea. Then we have the angular blepharitis. It is caused by the Moraxilla lacunata or Staph aureus, leading to red, scaly, macerated, fissured skin at the lateral canthus. Skin chafing secondary to tear overflow can look similar. Angular blepharitis, this is very important. It should be differentiated from the skin chafing secondary to tear overflow. The culprit microorganism is Moraxilla lacunata. Angular blepharitis is caused by Moraxilla or staph. Then diagnosis: patient present with burning, grittiness, and photophobia, that is mild rusting and redness of the lid margins, usually worse in the morning. Then we have the in case of staphylococcal blepharitis, scales and crusting around the base of the lashes, collarettes. These are the collarettes. Mild papillary conjunctivitis. And then we have the chronic conjunctival hyperemia. Long standing cases may develop scarring and notching, which is called as stylosis of the lid margin, as well as madarosis, loss of lashes, minus lashes, trichiasis, that is misdirected eyelashes, poliosis, that is premature whitening of the lashes. P for poliosis, P for premature whitening of the lashes. Secondary changes including styes. Okay, keep in mind, if there is staphylococcal blepharitis, it can lead to styes, marginal keratitis, and occasionally flectanulosis. Then seborrheic blepharitis. It is hyperemic and greasy anterior lid margin, adherence of lashes to each other, adherence of lashes to each other, hyperemic and greasy anterior lid margins. Then we have the posterior blepharitis, meibomian gland orifices showing pouting, recession or plugging, hyperemia, telangiectasia of posterior lid margins, oily and foamy tear film, very very important sign. Secondary changes including papillary conjunctivitis and inferior corneal punctate epithelial erosions. Associated with tear film instability and dry eye syndrome. Treatment is lid hygiene, warm compresses to soften the crust, lid cleaning to remove the crust, mechanically massaging the lid to express accumulating meibomian secretions, and tear substitutes for tear dysfunction. Topical antibiotics like the fusidic acid, bacitracin, or chloramphenicol ointment can be applied to the lid margin to treat acute folliculitis, but are limited value in long-standing cases. Oral antibiotics like azithro 500 mg daily for 3 days to control the acute exacerbations in staph. Oral tetracyclines are often highly effective but should not be used in children less than 12 years of age, in the pregnant or the breastfeeding women. So these are the pictures of the blepharitis. Chronic marginal blepharitis. A is for the staphylococcal blepharitis, B is for the matted lashes, seborrheic, C is for the meibomian gland dysfunction with the oily orifices, and D is for the foamy tear film. So oxytetracycline or doxycycline, this is commonly given in OPDs, 100 mg twice daily for the 1 week. पहले हफ्ते के लिए दिन में 2 दफ़ा एंड डेली फॉर 6 to 12 weeks. erythromycin or once or twice daily in alternative or tetracycline. Weak topical steroid like FML can be given 0.1% 3 to 4 times daily for 1 week in patient with severe papillary conjunctivitis with marginal keratitis. Then we have the thyriasis palpebrum. The crab louse Thyrus pubis is principally adapted. Sorry for the page. Thyriasis palpebrum. The crab louse is adapted to live in pubic hair. Pubic hair, but can also infest in the chest, axilla, or eyelids. Eyelash infestation. Thyriasis palpebrum typically affects children living in condition of poor hygiene, presentation, chronic irritation, itching. Lice anchored to the lashes. Ova and empty shells appear as brownish opalescent pearls adherent to the base of the cilia, and mechanical removal of the lice with forceps. Topical yellow mercuric oxide 1% of petroleum jelly can be used to the lashes and lids twice daily for 10 days. That's all for the